Hello, everyone. My name is Morshedian. I'm a medical science liaison at AVITA Medical. It's a pleasure to welcome you today to the 2025 SAWC Fall Meeting in Las Vegas. Today, I have the pleasure of speaking with Dr. Carmen Flores, a distinguished trauma and acute care surgeon from University Medical Center of South Nevada, where she recently has been assuming the position of the medical director of surgical services. Dr. Flores's academic journey began at University of California, Los Angeles, my own alma mater. Go Bruins.
Go Bruins.
She went to medical school at University of Illinois at Chicago Medical College, and then after finishing medical school, she came back to the West Coast and did her residency in general surgery at Maricopa Medical Center, the home of the Arizona Burn Center in Phoenix, Arizona. And then after completing her residency, she went to fellowship and did her fellowship right here in Las Vegas at University of Nevada, Las Vegas. Dr. Flores has an extensive history and background and knowledge in both academia and clinical practice and administrative roles. She has a wealth of knowledge and a deep desire to create change in the surgical care. So today, the title of her presentation is Redefining Acute Wound Healing, Innovative Science and Real-World Experience, where she's going to be talking to us about some of her experiences using AVITA's technology and products as a therapeutic acute wound therapy. Thank you so much, Dr. Flores, for being here. I know you're busy. I know you're traveling today, so I really,
Thank you
really
very much for having me. It is a pleasure to be here and a pleasure to talk to you all about some of what AVITA and the service line and the line of products and even the new products have done for my patients and my clinical practice. So without further ado, we will proceed, and we're going to start with some cases here. First off, as necessary, the disclosures. This is my disclosure slide. We will be talking about my own personal experiences. Many of the cases today are my own cases. So these are my own observations from my clinical practice. So a little bit of background about me and my journey with AVITA. I started using RECELL, which is the flagship product in the AVITA service line, back in 2018. I was a resident, and Arizona Burn Center was part of the clinical trials for RECELL. And back then we were using we had lots of patients afflicted with huge burns. And we, as you can imagine, lots of skin loss, lots of critical illness that comes with that, life-threatening illness. And we had to find a way to cover those patients as quickly as possible with skin, while treating all of the other complicated medical problems that come along with that. Back then, we would send off biopsies to a lab. Those skin cells, the patient's skin cells, would grow over the course of a couple of weeks, and we'd have to kind of wait and bide time while the patient was sick in our hospital. And then RECELL came along with the intention of being a point of care method to apply skin cells as quickly as possible in the operating room to get these patients covered.
How significant was that when you guys realized that this is a point of care treatment?
It was absolutely significant for us. And oddly enough, during that particular time when RECELL came on the scene, it was winter. We had several big burns in our institution. And we had just finished the summer season, which is very fast and furious in Arizona. And we had just finished that season, and we had used the biopsy method on multiple patients. And we waited a very long time for those patients to get covered. And so it was super impactful when RECELL came on the scene. We first used it on 2 very large burn patients that were involved in a Christmas tree fire, and were able to get those patients out of the hospital and back to their normal lives within a very quick period of time. And so those 2 cases started my journey even as a resident back then, and that was with RECELL. And so today we're going to talk about all three of the products in the AVITA lineup. AVITA has been a company that has been very, very intentional in their clinical practice, meaning many times we have our medical science liaisons and our RECELL reps in the operating room with us doing dressing changes at the bedside. Many of them have clinical backgrounds. And so that kind of sets AVITA apart from other industry partners. This is one of my cases. We're going to start with this gentleman who was run over by a backhoe in the back of an alley here in Vegas. He's a 47-year-old male, and he sustained traumatic injury. He had a bony fracture of his thigh, in addition to some skin avulsions that he had on his hand, most notably on the hand. And then very faintly, you can see that there is this area of bruising along his left thigh, which we call a Morel-Lavallée lesion. It's basically a slippage of the layers of skin against one another, which can cause very significant pressure and tissue death within the thigh. And this is what happened to this gentleman. So this is a patient that demonstrates from A to Z what our clinical practice is like and how we use the AVITA products and the tools from start to finish. And so this gentleman went back to the operating room the very first day that he presented. I was not on call, but he did go back and get his hand repaired. And without going into the rest of the story, we're going to go through the thought process first of, again, start to finish, how we would treat this patient. And so the patient went back to the operating room, had an excision only on the hand. The thigh was left alone. And the necrotic tissue and devitalized tissue, and then the native tissue was used to kind of flap over and repair that. Later on during his stay, we did notice that his thigh was getting worse, and we had to go in and excise or remove tissue from the thigh. And again, we removed all the necrotic and devitalized tissue, and then we realized we had to build a dermal base and then achieve definitive closure for this gentleman. And so you'll see way on the far left, that is his initial presentation, the photos that you saw on the previous slide. This is him post-injury day 6 in the second shot. And what you'll notice is, as I've stated, the left thigh got markedly worse, much pressure on that thigh and on the tissues underlying. And then went back to the OR to get that necrotic tissue off. And you can see how extensive the tissue death was on the thigh. It was actually more extensive than the pictures show here. Underlying all of that muscle was just dead muscle and myonecrosis. And so we had to take him back multiple times for a sequential excision all the way down to his femur bone.
So before you do anything, you have to make sure that you're removing all these dead tissue and necrotic tissues,
Yes.
and then you get the wound to a point where you can start building it back up, essentially.
Absolutely. And one of these pictures, the middle picture, post-injury day 6 of his hand, demonstrates what happens when not enough of that devitalized tissue comes off. And as you can imagine, that wound is not going to close very well with that devitalized tissue, no matter what product you use on it, or if you use a product at all. And so when we took him back post-injury day 6, we had to remove all the devitalized tissue on his hand as well as the thigh. Very, very, very important point, and kind of why burn surgeons and wound surgeons still exist, because we've got to have the clinical sense and the keen ability to know when to take off skin.
Absolutely.
And so this is the patient post-injury day 22, and you'll notice the second or the third step in his journey is the application of a dermal matrix. And a dermal matrix was placed both on the thigh and the hand so that we could develop a dermal scaffold. Patients cannot undergo any type of split thickness skin graft or coverage of that with their own skin until there is for lack of a better way to say it, a soil that has developed. And that's where the dermal matrices come in. So we placed dermal matrices on his thigh and his hand. And then we took him back to the OR and made sure that he was kind of cleaned up. Again, serial excisions, removing any devitalized tissue that had developed over that dermal scaffold that had developed, so that we knew a skin graft would take. And so we took him back post-injury day 49, and that's how kind of long it took for him to fill in, especially over the bone of the thigh. And we laid down some autograft to kind of test to see, will a skin graft take on him? Okay. And that was successful, and we took him back and laid down a 2-to-1 meshed autograft. So we took some skin from his thigh. You can see his donor site up on the thigh there, on the upper thigh. And it was really important for us, for him and all patients, to save and salvage whatever skin that you can on your donor site and make it the smallest donor site possible. And that is where RECELL comes in for coverage for him. We only wanted to take skin from the affected leg. We did not want to take any more skin from anywhere else. We only wanted him to have one injured leg.
Is it true that patients generally tend to complain more about pain in the donor site than the actual wound itself?
Yes. The donor site is fresh skin. We are taking a thin layer of epidermis and some of the layer of the dermis, and it can be excruciatingly painful for patients because we are exposing all of the nerve endings and fresh
right
skin.
Through those nerve endings.
Yes, and it is always the site of burden for patients. Even with extensive wounds and traumatic injuries, the donor site is always what they complain about.
So minimizing that is very significant.
Absolutely, especially with big burns and wounds. The other reason to minimize the donor site is so that you have enough skin to cover again multiple wounds. And so we took him back to the operating room, did a 2-to-1 meshed autograft, and I did choose a 2-to-1 meshed autograft in him because I wanted it to close very briskly, and I wanted him to get out of the hospital and be done and live his normal life. And this is him post-graft day 7. You can see his donor sites are almost all the way healed. There's a small little shot of the donor sites up at the top. And the interstices, or the small areas of open graft area, are already starting to fill in. His graft has laid down and attached very nicely on post-graft day 7, and he is on his way to recovery there. And so this is him post-graft day 13, and all the while, this gentleman is able to get up and move around with physical therapy. He's able to bend his knee. He's able to start doing activities of daily life very, very quickly post-operative day 1 after his graft. When we use RECELL and spray over a patient's graft, they are able to get up out of bed very, very soon. Physical therapy is very important for them. And so you can see in this photo that his hand has completely healed. We did a sheet graft and sewed on that graft to his hand. And his donor sites on his thigh are healing almost all the way epidermalized or filled in. And his graft is 100% healed at this point. His limb functionality was restored 2 months post-op, and very, very quickly for a gentleman who had bone exposed and his femur exposed after his injury. He eventually was lost to follow-up shortly after, not uncommon in Vegas, shortly after his first post-op visit. Because his graft was filled in, he was happy, he was done. And so he was lost to follow-up and did not come back, but that's a good thing.
That's a good sign, right?
Yes.
So one thing I just want to clarify, in this particular case, the only product of AVITA that you used was RECELL.
Yes.
Is that correct?
Yes, and we will go into that in the slides upcoming, but I did want to introduce the dermal substitutes, because that brings us to kind of the next kid on the block in the lineup for AVITA. And I think early on, again, AVITA being a company that is very clinically focused, lots of clinical experience for our industry partners at AVITA. I think what they realized early on is we did have a method for coverage of patients spray skin, RECELL. And but there was not something in the lineup that can function as a dermal substitute to lay down that skin. And so it was important to them to develop a product, and that's where Cohealyx comes into the scene. But before we go into Cohealyx, we'll talk a little bit more about RECELL. The RECELL Go system is a method for us to harvest skin cells. And so the process in the operating room is we harvest a small piece of skin at 8/1000ths of an inch from the donor site. And that skin is processed or enzymatically broken down to create a skin slurry so that we can use it to spray either on a partial thickness burn or wound directly or over a graft, as we saw in our previous slides there. And so one small piece of skin, even 1 centimeter or squared centimeter piece of skin, can expand to cover 80 square centimeters of wound. And that is very, very big, a big deal. Not only because the wound can be covered very quickly and closed, but also because in very, very big wounds and burns, you get closure very soon, and you can use less skin and have more coverage.
And that's where that reduction in donor site comes
Absolutely. The first kind of iteration of the RECELL system was with an ease of use, and we formerly scraped skin cells from the skin itself that we harvested, but now the Go system is in all of our operating rooms in Las Vegas, and the machine does the job for us while we are doing other things in the OR. And so we apply or insert our harvested skin into the RECELL Go system. If we are using a full RECELL Go system, which consists of 4 syringes of product, we are able to cover a little bit less than 2,000 square centimeters of wound. And now, most recently, the Mini Go, we are able to cover a small area of that for smaller wounds, facial wounds, and smaller burns. And so, like we've stated before, we obtain a skin sample, 8/1000ths of an inch, and those are enzymatically broken down in the RECELL Go system to create a slurry or a spray skin, and those spray skin cells are applied directly onto a partial thickness or a superficial burn or wound, and or on top of a scaffold or an autograft, a 2-to-1 meshed autograft, or a wider meshed autograft that you've laid down. One thing that has changed in my own practice, harvesting so thin for a RECELL sample, is that I now harvest my donor sites more thin. Meaning I will usually, if I am covering a large burn or wound, I will take smaller and thinner swipes of tissue, which does a couple things. It allows me to have the same coverage over a wound, but it also allows the donor site, which is the biggest morbidity in these patients, to heal faster.
And the reason that works is because you want to be right at the dermal-epidermal junction.
Yes.
Right? That's where the good cells, those are the cells that you want to harvest.
Correct. And we were able to get that.
It's kind of counterintuitive,
Yes.
right? The thinner you go, you feel like this is not going to be enough. But
Correct.
The reality is, anatomically, you're going to be at the right position. You're going to be exactly where you need to be.
Absolutely. And, we have seen, unfortunately, many patients who have had very deeply harvested donor sites, and those end up becoming the new wound for the patients and can be a significant burden for them. So as we've stated before, the Go system is now in all of our operating rooms. The clinical impact of RECELL overall is that we are able to spare donor sites with an accelerated healing. Cosmesis is a lot of times we don't discuss that, and it's very, very important for these patients, especially patients with facial burns, and even with skin grafts over their body. Not everyone likes or appreciates that they have this cross-hatched marking on their skin grafts. And that's where RECELL comes in. You're able to fill in those interstices, and a lot of times those interstices fill in so much that you can hardly tell they've had a meshed autograft. Operational efficiency in the OR with the GO system, we are able to do other things in the operating room while the skin is enzymatically processed, and we're able to develop our spray skin in the OR. Length of stay is a very big issue across hospitals. The increased burden of hospital costs and healthcare costs is a big deal. And so the faster you get these patients covered, the less chance that they're in the hospital. Yeah. It is a very, very big burden here, specifically in Las Vegas, because the outpatient care is not the best, and their access for our patients is not the best to aftercare. And so a lot of times with RECELL, we are able to cover them faster and get them out of the hospital, but also get them out of the hospital with a completely closed wound, which is a very, very big benefit. The other thing that we're able to do is those patients who do have good follow-up and are able to come to the clinic, sometimes they're leaving the same day they get a graft, and we cover them and they come back to the clinic and we take the graft down and they're healed. And so that also decreases the length of stay. Incredible. And so that translates into an economic value, lower treatment cost per patient, again, less length of stay, less product being used, less healthcare cost, and increased patient throughput. What we've demonstrated here on these slides is very important because this is kind of the fork in the road for surgeons to decide when they're going to lay down a graft and when they're going to just spray the skin slurry over a partial thickness or a superficial wound or burn. So, and I think both of these methods kind of make an impact to clinical care. So for partial thickness burns and wounds, there are dermal elements within those burns and wounds that are left after the trauma that communicate with one another and help any epidermis that you lay on as a spray to grow skin again. And so these patients usually do not need a widely meshed autograft at all because they have the dermal elements that the graft would provide them already. The application of RECELL to a partial thickness burn and wound is a big deal because patients get out of the hospital sooner. I will give you a great example of this. Many moons ago, there was this thinking that we had to wait for burns to declare themselves or to figure out how deep they were going to get. And so a lot of times, partial thickness burns that were high TBSA would stay in the hospital while we waited to see, do they need surgery, do they not? A few months ago, I had a patient who was flash burned by a barbecue grill in her backyard, and she sustained 18% TBSA, and they were partial thickness burns. And when I came on service, she had already been in the hospital in topical ointment for probably 3 days already. I took her back to the OR, took a very small segment of skin, ran it through the ease of use kit, and we were able to cover all of that 18%, and she left the hospital with almost full epidermalization of her burns in about 5 days.
I believe one of the issues with waiting longer is that it increases the probability of developing hypertrophic scarring as well. So you want to close that wound and have that physiological healing as soon as possible.
Absolutely. And so those types of patients, hospital day 2, going back to the OR and laying down, taking a small area of donor site and laying down spray skin can make a huge difference for them, not only from a recovery standpoint, but a length of stay standpoint. This particular patient had lots of burns on her face and on her neck. She was very, very cosmetically sensitive to that. And she left the hospital with a healed face in about 5 days. And so that's kind of where the skin slurry alone comes into play. For full thickness wounds and burns, traumatic wounds, burns, surgical wounds like flap donor sites, amputation stumps that don't heal, fasciotomy sites, those patients usually need a widely meshed autograft to lay down because they need the soil and the elements necessary for the epidermis to grow again and cover that wound. And so for those patients, we lay down a scaffold, provide the dermal elements necessary, and then spray over the interstices for those patients. Lots of patients like this in Vegas, lots of neck fash, lots of traumatic wounds. One of the great impacts that RECELL and AVITA have made is in the area of academics and research. And not many products in this space, in the burn space or in the soft tissue space, can boast this. And so we are backed by 180 plus publications in the clinical and scientific data. And this is very, very big because this demonstrates the impact that we've had on patients. And it is backed up with the science. We've talked about some of the wounds that we're able to cover with RECELL, and pretty soon we'll talk about Cohealyx and PermeaDerm. But I have applied RECELL just about every single one of these types of wounds. Hematoma areas, deep soft tissue injuries, calcaneal wounds on the feet that people think are not going to heal and we need an amputation for. Very, very big in limb salvage at this point in time. We've got lots of podiatrists that are using this to save people's limbs. Open abdomens, necrotizing soft tissue infections, blast injuries, gunshot wounds, and fasciotomy sites. So just about anywhere that you can think of, we use RECELL. This is another one of my cases. This is a traumatic injury. This gentleman was a school teacher. We have a very, very big street here, Charleston Boulevard, and Charleston is one of the main thoroughfares in Vegas. And people come to Vegas and visit and like to speed down Charleston on in their vehicle or on their motorcycle. Very, very normal, well-meaning people get into trouble that way, and this gentleman was no exception. And so 56-year-old school teacher crashed his motorcycle on Charleston, and this was his initial degloving wound. Again, I was not on service when this patient came in. The crew took him back. You can see he's got some devitalized tissue already on that skin flap there, some necrosis happening. But he was taken back, and the native tissue was used to cover that, and it did not survive because it's necrotic. Mm-hmm. And so we took him back for several serial excisions and then laid down again the dermal substitute that you see in the second photo. So the dermal substitute, again, is providing a scaffold because you can't just lay an autograft down there. It won't take, and you're gonna waste the patient's skin. And so we waited for that to kind of fill in, watched that a little bit, applied some compression. He was able to walk and all of these things in the meantime. And then we took him back to cover him with RECELL. He was a very active guy, and so time was of the essence, just like with any other patient. And so we used a 2-to-1 meshed autograft, covered him with RECELL, and this is what he looked like post-graft day 4. You can see some of the epidermalization that's happening on the upper and the lower leg there. He did get vacuum coverage, wound vac coverage, and then 3 weeks later he has a covered wound. Some small areas. He unfortunately was not the best rule follower, and so went swimming just before complete closure of his graft.
In Vegas.
Yes, we have lots of trends in Vegas, and so he decided to go swimming in the beach in Costa Rica, and but his skin stood the test of time, and he did quite well and got back to teaching. So great case there. This particular slide is one of my favorites, and the reason why it kind of breaks down from a microscopic level the elements that are in the skin slurry. And so the skin slurry or the spray skin consists of keratinocytes, fibroblasts, and melanocytes. Keratinocytes for barrier function, fibroblasts to provide new extracellular matrix proteins, and melanocytes, which come in way late to the game, but very, very important because they provide the new pigment that the patients need. Very, very important, especially in cosmetically sensitive areas like the face. The biggest question I get asked from patients with burns and wounds to their face is my pigment going to be different on my face? And the answer is no. So when we use RECELL on the face, there is a great pigment match, great cosmesis, which is obviously a favorable outcome for the patient. This is a demonstration of how RECELL is applied in the operating room, and you can see kind of how it is sprayed into the wound itself across the entire wound bed, and it fills in because you're able to spread so much product within the wound bed itself and get a very, very good coverage. The wound regimen or the dressing regimen for RECELL consists of an outer dressing, which is changed 2 to 3 days post-op, followed by a secondary dressing or absorptive dressing and a non-adherent dressing. And even by day 3 post-op, you can start seeing those interstices fill in. We've talked a little bit about this before with the length of stay savings, which translates into a tremendous cost savings for the healthcare industry as a whole. We demonstrated a 13% reduction in costs in length of stay, rather, translating to a $26,000 cost savings per patient in the first trial that we ran, which was in patients with less than 50% TBSA burns. And then that was followed by a less than 30% burn trial in which we demonstrated a 36% reduction in stay. So again,
so the 13% is for full thickness burns and the 36% is for the partial thickness, right?
Correct. So the less...
And
yes.
Is that something that you've seen in your institution?
Absolutely,
as well, right?
absolutely. Again, here in Vegas, very poor access to outpatient care. And so the faster we can get the wounds covered, the faster we can get them to the operating room, the patient saves and the patient gets back to their lives. We've gone through some of this already with the harvest preparation and application of RECELL. Each one of those steps in the process are backed by codes. We'll move on now to the Cohealyx, which is, again, the newer kid on the block, the skin substitute, which is made of bovine dermal collagen, both types 1 and type 3, both very necessary in the healing process, with ideal pore size and controlled resorption, which translates into good adherence to the wound bed itself and a very, very good pace of healing. So a lot of times what we see with products, other dermal substitutes are they either create a neodermis or a dermis that isn't quite ready for a graft. Sometimes we don't know what it's made of, if you can imagine. And so Cohealyx we are in the process of conducting a trial on Cohealyx, but I think a lot of clinicians are attracted to it because it is collagen based and it is a biologic, and we can kind of count on its fidelity. We'll have to see what the trials show, but so far, I have personally used the product and have had pretty decent success. We'll see some slides that come up here to support that. Early anecdotal data has shown us that autografting can happen a little bit sooner with Cohealyx than with other products. It is very thin, it's compressible. The other thing I will say about the product and having used it is that it doesn't have a side. And so in the operating room, it's very easy to apply.
It's monolayer.
It's monolayer. It is as soon as you lay it down, it conforms to the tissue underlying, which is great. And so here's a demonstration of that. The wound bed is prepared as removing all the devitalized skin and the necrotic tissue. Cohealyx is applied. You can see even without hydrating it, it already is conforming to the wound bed itself. The excess is trimmed, and then it is hydrated and secured. And I have secured Cohealyx with staples. Sometimes I haven't secured it at all, and it adheres pretty well.
The handling is, can you say a little bit about the handling?
Yes, the handling.
There's quite a difference between when it's dry and when it's hydrated.
Yes, so we'll go back to this one. So when it is dry, it does kind of pull apart very, very well. Sometimes a little too well, so you got to kind of be careful when you're laying it down to make sure that every single area of the wound is covered. Once it is hydrated, it kind of conforms to the underlying tissue, but I have laid it down on a dry surface and not hydrated it and kind of allowed the tissue underlying to moisturize it, which has worked quite well in keeping it in place and adhere to the wound bed. So I've kind of used it in both ways. This is one of my cases, 67-year-old male. He had a necrotizing soft tissue infection, very unfortunate gentleman, diabetic, uncontrolled diabetes, DVT, peripheral vascular disease. And so he had to go back to the operating room emergently for an amputation of his fifth digit and his fifth toe on his right foot. Very bad necrotizing soft tissue infection, lots of devitalized tissue. You can see that we excised him all the way down to tendon and muscle there, and even bone. The bony joint of his ankle was exposed. We took him back to the OR after excising him twice and applied Cohealyx. You can see there, we did hydrate it, and we laid it down with a bunch of staples. I don't do that anymore. I found that I really don't need to over-secure it. Mm-hmm. Staples can be a big burden for patients. They hurt. They can be a very big source of pain. And when we can conserve that's great. This is the patient post application day 5, and you can see that the Cohealyx has kind of already integrated. There's granulation tissue starting to crawl over that tendon. Post application day 14, this gentleman was lost to follow-up. He had osteomyelitis of the ankle, didn't quite adhere to the antibiotic regimen, and came back a few times post-op after the first application with heart block. He needed a pacemaker. He was diagnosed with a DVT and just needed a lot of care apart from his wound. But we continued to forge forward with him. These are actually photos from the cath lab. Right after his pacemaker was placed, we prepped his foot, and we laid down another round of Cohealyx. And 1 month post-application, his tendon is covered and he's ready for grafting. We took him back to the OR, excised him and debrided him again, and then laid down a 2-to-1 meshed autograft and RECELL with a small donor site up on the thigh. We actually used a mini kit for him because he didn't need that much coverage. And by post-graft day 7, his interstices were filled, and then by day 10, he was ready to go home. This is a sample of what we talked about before with a very thin donor site and how quickly it heals. By day 7, most of my donor sites are fully epidermalized, which again is a great, great benefit for the patient with regard to pain and morbidity. As we've stated before, there is a multi-center trial underway for Cohealyx, with the primary endpoint being time to skin grafting and graft take with wound healing and scar outcomes. Again, some anecdotally, some practitioners are seeing early grafting ability as early as post-application day 7.
There's a preclinical evidence
Correct.
on a porcine animal that demonstrates that.
Awesome. And finally, the newest kid on the block is PermeaDerm. Again, similar to the rationale with the development of Cohealyx, the folks at AVITA wanted to find a way to temporarily cover wounds. For many, many years in the burn and the wound space, we have been using allograft or human cadaver skin to temporarily cover burns and wounds. And I think PermeaDerm is in that line of thinking. Without further ado, this is what PermeaDerm is. And so it is an outer layer of silicone, which protects the wound itself from bacteria and trauma, which kind of seals the wound. And it kind of manages the exudate and the products and the fluid that can develop over the wound that can cause not only colonization, but infection. The inner layer consists of a bioactive coated nylon matrix, which expedites healing. Many, many practitioners are using this in the superficial and partial thickness burn and wound space and finding tremendous, tremendous benefits, even without using it as just a simple temporary dressing. The clinical impact here is, as we've stated, it adheres very, very well to the wound bed. It kind of seals in and onto the wound itself to prevent colonization and infection, reducing the need for dressing changes because you don't have to take it on and off, which is, again, a significant morbidity for the patient. It is customizable moisture management and kind of controls the moisture at the wound bed surface itself. And it comes in large sheets and gloves, which is great for very busy surgeons like me who kind of loathe dressing fingers and toes. The glove options are great in that respect. The economic value of not having to do dressing changes and changing out multiple dressings at a time is also a benefit for PermeaDerm. This is an example of one of those surgeons that is able to optimize the use of PermeaDerm in partial thickness or mixed thickness burns. So this is a 12-year-old female who sustained a 6% TBSA burn on her lower extremity. And you can tell it's partial thickness, maybe some deep areas there. The PermeaDerm was laid down, and post-application day 8, you can tell underneath that PermeaDerm, it's starting to lift, which means that the wound underneath is epidermalizing and kind of pushing the product off. And that's exactly what you want it to do. By post-application day 15, she is re-epithelialized and probably at home already. 6 months post-application, no scarring, and you can't even tell that she was burned. And so very, very big opportunities and outlook for PermeaDerm in patients like this. You can tell here in this particular photo that the surgeon has placed PermeaDerm on a very, very large area, very big sheet, which again translates to cost savings. There's currently a trial, multi-center trial going on to compare PermeaDerm to cadaver skin, which is again a product that we've used very, very for very long in the burn space. And those comparisons are based on the cost and the financial burden of the hospital compared to cadaver skin. The wound bed visualization with cadaver skin, sometimes you can't see underneath and you can't tell when it's epidermalized. No tissue tracking, no disease transmission risk. And then it doesn't really have very much burden to store it, which is a big deal. Cadaver skin, we've got to take up freezer space in the OR for that. This is a 67-year-old female that sustained a 2% TBSA surgically excised injury to her hand. The surgeon has laid down PermeaDerm in that second photo there. You can tell this is a mixed depth type of wound. and the PermeaDerm sticks quite nicely. Not much fixation, again, necessary because it kind of sucks on and sticks on very, very well to wounds. By day 9, the PermeaDerm is removed. You can see some epidermalization. You can see some granulation tissue. And then the surgeon has laid down a split thickness autograft, which has adhered quite well to that hand. This is the multi-center trial we referenced in comparing PermeaDerm to cadaver skin or allograft, with the primary endpoint being a reduction of cost per total body surface area, and including patients who have been surgically excised and are ready for kind of a temporary coverage. We are going to also look at operative time, time to healing, time to graft, and then length of stay. So AVITA, as we've stated, has kind of looked at the whole lineup and of from A to Z in the clinical treatment of patients with burns and wounds, from the time of excision to the time of needing a possible dermal substitute or developing a wound bed for grafting, to grafting itself. For both partial thickness and full thickness burns and traumatic wounds. There is much clinical support in the operating room. I cannot stress that enough, and how valuable it is, both in the operating room and on the floor, following dressing changes, helping us to attend to the patient on the floor. I've had medical science liaisons that help get my patient the physical therapy they need. All areas of support, they are briskly and very heavily involved in. Medical education, peer-to-peer education is very important for us as surgeons, and AVITA supports that, as well as patient access and access to aftercare. Health economics is important, coding, coverage, and reimbursement. AVITA does kind of help us with that, knowing the latest and the greatest with the coding changes and reimbursement, which is helpful. And so this final slide of my patient that got run over by a backhoe kind of shows again, start to finish impact of the AVITA and the line of products that we are looking for as surgeons. Basically, almost a one-stop shop for us. We will see what the multi-centers trials show. Very, very hopefully and anxiously looking forward to that for PermeaDerm and Cohealyx. This is a slide that kind of incorporates everything we've talked about for partial thickness, deep partial thickness, and full thickness wounds. Partial thickness wounds with PermeaDerm. I would even add RECELL to that for those partial thickness burns and quick coverage. Deep partial thickness or mixed depth burns and wounds, combining PermeaDerm with RECELL, whether it's for temporary or topical coverage using PermeaDerm, and then covering those definitively with RECELL. And then full thickness burns and wounds, adding Cohealyx to the mix as a dermal matrix to support a future autograft, and using PermeaDerm as either a temporary coverage or as a definitive coverage for any partial thickness or donor sites that patient may have. And so the AVITA lineup, as it stands, supports every stage of wound care and treatment for soft tissue and burn patients, reducing patient burden, lowering healthcare costs, as we've seen, and then helping patients get back to their lives sooner.
So, Dr. Flores, I have two quick questions for you.
Yes.
With my first question, I've always wondered, what is the reaction that you get from patients when you tell them that you're going to harvest a small piece of their skin, you're going to create a suspension, and you're going to spray that back on their wound? What is the reaction?
So those patients who don't already know about RECELL are flabbergasted. It's very hard for them to wrap their mind around it. I have had many patients who come in and say, I saw this on the internet and I want to know if your center has this. But those patients who don't know They are very, very excited. Some of them are apprehensive, but when they see the results, I think they are very happy with that. I think one of the biggest impacts again have been the cosmetic outcome, especially for young patients, children. Across the board, I think I've had patients cry in my office from having their face healed so quickly and not being disfigured from their traumatic injury or burns. So I think that has been probably the most impactful.
And then my last question for you is, what advice do you have to surgeons, to wound care specialists that are thinking about adopting these novel technologies into their practice?
I think one of the biggest pieces of advice that I have is know your institution, know the capabilities, and know your patient population. I think now that AVITA has kind of covered every step in the process, to use those products as they were intended, and then to develop your own clinical practices to support what's best for your patients. I think it's important to understand that. And one of the best examples I have of that is burns and wounds respond to regional variances. So what I do here in Vegas and what we did back in Arizona is much different from what is done sometimes on the East Coast or the Midwest. And some of that is climate variable. Some of it is based on antibiograms for wound infection in a particular institution. So I think not being rigid and kind of understanding that sometimes you have to bend and be flexible as a burn and wound surgeon is important.
Thank you so much for being here with us. Really appreciate your time.
Absolutely. Thank you very much for having me.